Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
This program is presented by Medscape Education Global.
Welcome to all of you. My name is Tina Vilsbøl. I am a consultant at Steno Diabetes Center in Copenhagen and a professor also at the University of Copenhagen in Denmark. Welcome to this program, which is titled Lack of Adherence to Basal Insulin. Are once-weekly formulations the solution? Today, Harpreet Bayai, who is an endocrinologist and medical director at LMC Healthcare Centricity Research in Ontario, Canada, is joining me. Welcome, Harpreet.
Thank you, Tina. My pleasure.
So let's get started. And before we start talking about modern insulin treatment, we would really like to take you just a little bit back, because many of you know that it's just recently that we actually celebrated the 100-year anniversary of the discovery of insulin, and a lot of things have happened since then. We went from having pig's insulin to having more and more modern insulin therapies, and actually also the recent years we have had really, really good insulin analogs. Some of them are short-acting, some of them are longer-acting, better and better drugs with pharmacokinetic profiles which are closer to normal physiology, and we are able to individualize actually and very much indeed design an insulin therapy targeting the individual needs for patients. But it doesn't stop with the really good insulin analogs, because just recently in Canada, where Harpreet is, and not yet in Denmark, where I am, the first once-weekly insulin was actually launched, and there are more to come. Now, when we look at the guidelines, insulin is still a really, really important backbone in the treatment of type 2 diabetes. And if you're worried about patient being very catabolic or in an acute state, it's always the right thing to initiate insulin from the start. And then we, in the outpatient clinic, can always reconsider what to do thereafter and what to add with respect to the more modern insulin treatment. Basal insulin is usually where we start, and then, if needed, we add basal bolus insulin. But what the main focus of this presentation by Harpreet and I today is actually to look into where are we right now and a little bit into the future. And right now, Efsitora Alpha's phase 3 program is called the QUINT program, and there are 4 trials, and then insulin icodec, which phase 3 program is called Onwards 1 to 5, also where insulin icodec is evaluated in different settings. But I'll now give the opportunity to get Harpreet on board, and please, Harpreet, if you can take us a little bit through the data. What are the data actually right now with respect to these new once-weekly insulins?
Sure, Tina. Thanks for that introduction. And if you, to begin with, told me that we could have a once-weekly insulin that has similar efficacy and hypoglycemia safety compared to a daily insulin, it'll be a no-brainer which one I would choose if I was the patient. So let me take you through some of these phase 3 trials, starting with the Efsitora. So their first phase 3 trial, which was presented and published this year, is the QUINT-2 trial in insulin-naive people with type 2 diabetes. So this compares Efsitora alpha once weekly versus degludec once daily. And as you can see in the graph to the left, that in the overall population, as well as the 50% of participants who were using GLP-1 receptor agonists at baseline, efsitora alpha had a similar reduction in hemoglobin A1C compared to degludec at the week 52 visit. Also to the right, if you can see, the A1C mean was under 7% at the end of the trial, which was non-inferior to degludec. So in terms of icodec, which is available in Canada, we have the Onwards 1 to 5 trials, and this is a meta-analysis of those 5 trials in type 2 diabetes. So if you look at the top graph there, the overall type 2 diabetes pool, as well as any of those subgroups, so insulin naive pool or insulin experienced pool, as well as when you compare it to glargine U100 or the degludec as a comparator, you have A1C, not just non-inferiority, but also superiority. So the A1C reduction in the blue bar for icodec is about 0.2 to 0.4% better on the A1C scale in this meta-analysis of the Onwards 1 to 5 trials in type 2 diabetes. And the bottom graph is not just showing us A1C, but also odds of achieving the target A1C of 7% or less. And in that too, the overall type 2 diabetes pool, as well as the other bars that are there, favor icodec compared to the daily basal insulins. So that's a very reassuring kind of data in terms of looking at efficacy for the once weekly insulin versus the daily insulins, Tina.
Yeah, and exactly as you, when we first heard about this insulin, we said, well, that's almost what I would call a no-brainer. However, I recall when I heard about it the first time, one of the things I was really worried about is hypoglycemia. Can it really be that you can take 7 times as much insulin, and even with a loading dose, without inducing a risk of hypoglycemia in our patients? And can you just take us through what's the status? What do you tell your patients about this, and what's the evidence, Harpreet?
Yeah, so just like you, Tina, one of my concerns was around hypoglycemia. And let me take you through the data. So here's QUINT-2 data, the same efsitora trial that we looked at for efficacy. So either of these rows that you look at, whether it's the hypoglycemia alert value, which is level 1 hypoglycemia, the clinically significant hypoglycemia or level 2 hypoglycemia, or any of these other rows, including nocturnal hypoglycemic episodes, there is no statistical difference in the hypoglycemia rates for efsitora versus degludec. Importantly, the severe hypoglycemia is actually 0 in the efsitora group as well, which is very, very reassuring. Similarly, when we look at the icodec data, and this is the same meta-analysis from Onwards 1 to 5 in people with type 2 diabetes, again, looking at the bottom, which is a pooled type 2 diabetes, or any of those other trials, you look at the incidence of clinically significant hypoglycemia or level 2 hypoglycemia, the p-value does not reach statistical significance. Hence, similar incidence of hypoglycemia level 2 for icodec versus the once daily comparators. Now, I should say that the rates overall were very low. The rates were 1.15 episodes per participant year of exposure for icodec versus 1 episode per participant year of exposure for the once daily comparators. Also, the severe hypoglycemic episodes were actually fewer with icodec. So the icodec participants had 8 episodes versus 18 for the once daily comparators, which is very, very reassuring overall. So if I could summarize, Tina, we have similar or better efficacy, for example, with icodec in terms of A1C reduction, but also we have very reassuring safety data in terms of hypoglycemia. The other concern regarding hypoglycemia, which we've shown in previous trials in both efsitora as well as with icodec, is regarding similar duration of hypoglycemia. So despite the longer duration of action of this insulin, we have not seen a longer duration of hypoglycemia for this basal insulin, which is very good. I could ask you, what do you think is the best patient profile for initiating these once weekly insulins?
Yeah, and that's a really good question. I know in many countries we often start with insulin glargine biosimilar, but many patients do not take their insulin because they get hypos and it's complicated. So I would definitely say to avoid therapeutic inertia, patients who are not good in respect to compliance, patients who are dysregulated, who really tend to forget their medication, and also, I mean, patients who need assistance for taking the injections. So you only need to help them once a week compared to 7 times a week. And it's definitely when I do not induce more hypoglycemia in these individuals. So it is much more simple. I mean, it's 52 times per year, right, compared to 365 injections per year. So I don't know what if you have any other suggestions in this aspect, Harpreet.
I would just add that if cost and access were similar, I would prefer a once weekly insulin with the data that we have, and with my clinical experience as well. We don't realize how many patients actually miss taking their daily insulin injection as such. So I think once weekly insulin reduces that burden and improves adherence to the insulin regimen, and hence should help reduce the complications of diabetes by achieving targets.
Yeah. And then how do you actually initiate a patient from being on daily insulin to starting a once weekly injection? Do you use the loading dose concept or what?
So if we are initiating in an insulin-naive patient in icodec in the phase 3 onwards trials, there was no loading dose used. So the initial dose was 70 units per week, which is just 10 units times 7. 10 units per day is what we use for daily basal insulin times 7 for the week, and 70 units. Now in FCTORA, there are different protocols, and some of the protocols, even in insulin-naive participants, have used a loading dose. So we'll have to see what the results show up in terms of different protocols of initiation for FCTORA. Now, let me ask you, once you initiate, Tina, how do you best titrate the dose of weekly insulin in your patients?
Yeah, I was actually part of the ONWARDS 3 program, which was patients who were insulin naive, and then they were either put on daily insulin or once weekly insulin. And it is actually very simple for us as clinicians who have used this before, because with icodec, you just pretty much use 7 times as much as you would from a clinical point of view. But of course, we are doctors and nurses around the patient, and we individualize it. It also depends very much on where are the patients in respect to glycemic control. Do they have skyrocket high HbA1c? Then we give them more basal insulin, and I would definitely also give them more once weekly insulin. And am I worried about hypoglycemia? And that accounts for both daily and once weekly insulin. I'm more, I do the titration a little bit slower. So I think we still need to use the art in being a good clinician and look at the patient and see where they are and where we want to go. One of the things I know a lot of people have been worried about, and also patient, is what about physical exercise? Do you have experience with that, Harpreet? And what's the knowledge from the trials in these patients, and also patients who actually have hypoglycemia and are admitted to the hospital?
Yeah, so in regards to any of those situations, Tina, as long as we are using the weekly basal insulin as just a basal insulin and not covering for postprandial excursions, so in a way we say not over basalizing, then it should be okay, because if the insulin is there just to reduce the hepatic glucose output, then it should not lead to problems. Now, in the onwards trials, as well as in the FCTORA Quint trials, there was no limitation or restriction in terms of physical activity. And of course, some people were hospitalized during these trials for different reasons in their daily life as well. Onwards, trials results in terms of hypoglycemia induced by physical activity or during hospitalization have been shared in previous congresses earlier this year and last year, and suggest quite a good safety profile in terms of physical activity induced hypoglycemia, as well as any hypoglycemia during hospitalization as well. In my experience too, I've not seen any differences in terms of hypoglycemia in my real life patient experience as well. When people undergo any physical activity or hospitalization, I have not had any concerns as such. Maybe I'll ask you a question, Tina, around that hypoglycemia, and how do you think we should deal with hypoglycemia, whether it is different for how you manage hypoglycemia with once weekly insulin versus a once daily insulin basal?
Well, what I've seen in the trial, I'm very confident that it is at the same level, and I think we should do as we always do. We should do our very best to avoid that patients do get hypoglycemia. And if you do that on a basal or a once weekly insulin, or once daily or once weekly, I would down titrate the insulin dose. I would talk to the patients about symptoms. And I would do exactly as I do and have done for more than a decade with my patients. And my whole idea is to, of course, have modern treatment on board, SGLT2 and GLP-1, which we know is in general glucose stabilizing, and that has also been shown in both the QUINT and the Onwards program. So I think we can talk about this for a long time, but I'll do my best just to summarize in short. We've now had insulin, or we have not, but insulin has been in the hands of the clinicians for more than 100 years. A lot of things have happened. We have really good insulin analogs. Many of them, when we talk type 2 diabetes, are once daily. Right now, there are two. Insulin icodec, which was evaluated in the Onwards program, and Ifcitora, evaluated in the QUINT program. Once weekly insulin, efficacious, significant, relevant, and what we've seen in the trials, sustained effect, safe in respect to hypoglycemia, even hypoglycemia or glucose control during exercise. Treat hypoglycemia as we usually do, looking into patients with challenges with compliance. If we had them to the same price or even lower, we might use them even more. And that's why it's good with competition. And then we'll see in the future, we might get glucose sensitive insulins and other insulins. So it is, in short, to be continued, and I am very much looking forward to the future. Harpreet, I really enjoyed the discussion with you. It was great to have you on board, and wonderful to see you here.
Me too, Tina. Thank you, and it was good to see you as well.
So thank you for your participation in this activity. Please continue to answer the questions that follow, and also, very importantly, complete the evaluation. Thank you very much for being here.
This program was presented by Medscape Education Global.